Hi everyone, and welcome to the Assist with Medication training. I'm Adam Dalzotto, and I'm the registered nurse here. I'm going to go through two slides, so this will be the first one. Okay, so let's get started. So first, I'd like to just acknowledge the Kaurna people as the local custodians of the lands and waters of the Adelaide region on which I'm presenting today. I'd like to also pay respects to elders past, present, as well as those emerging. Also acknowledging and respecting the Kaurna people's cultural, spiritual, physical and emotional connections to their lands, waters and community too. So first we'll get started with seeing what CLO's medication policy looks like. What you see on the screen there is what we have currently in place. This should be accessible everywhere you go. So there should be a printed version on site, there should be one on SharePoint, and you should just be able to easily access this at any point. This is your go-to guide for anything medication based. So a few of the main points I'd like to draw your attention to from this policy is that the person that prepares the medication must be the one that gives it to the client. So you can't just prepare it and ask someone else to give it. And similarly, someone else can't prepare it and ask you to give it. You need to be there for the entire process. If you're not, it's not safe for you to give it because you cannot guarantee that the other person completed all of their rights and all of their checks. So this is really about safety for you and for your client. So if anyone ever asks you to give a medication that you haven't prepared and you haven't checked, you need to refuse that offer. Something else that you might find interesting is that we refer to senior staff members or senior on shift. All that relates to is the person that has worked with the client the longest, the person that has the most experience working with them. So seniority is not something that we utilize at CLO. It is just based on who gives the medication on shift. So the next 2 points here are interlinked. So you've got the Schedule 8 medications, and these medications are often known as drugs of dependence. So these are endones, morphine, codeine, anything that someone could quite easily become addicted to. These medications need to have 2 people prepare, administer, and sign for the medication. Okay, so this is to ensure safety for both of the people preparing the medication, and if anything does go wrong, you've got 2 people backing each other up. So I'm going to start with duty of care, and I'm going to read that first line verbatim. So duty of care refers to the responsibility imposed on an individual requiring adherence to a standard of reasonable care while performing any acts that could foreseeably harm others. What that means is essentially you're not going out of your way to put someone's life at risk. So you're going driving with your client and your client refuses to put on their seatbelt, you don't drive the car. It's really that simple. What we're looking for is that awareness of self and of the situation. Am I putting myself in danger? Am I putting my client in danger? Am I putting the public at danger? Okay, so your duty of care is to ensure that your client is safe. When we refer back to medication, what we're talking about there is, have I done the checks? Am I giving this medication and do I know what I'm giving? That's all part of your duty of care. Okay, so you need to be able to support your clients in ways that are consistent with your level and training. Okay, so if you haven't been trained with Assist with Meds before, you shouldn't be giving medication. It's that simple. Okay, because you're putting people's lives at risk. You need to be familiar with the policy at CLO. You need to also have had the training. So you get the theoretical here, and we're going to have a practical assessment later on. You need to have demonstrated competency of the skills, practiced, and when you're on shift, once you have completed the Assist with Medication training, you should be able to safely administer medication, even if it takes you a little bit longer than usual because you're nervous. It's no problem, that's very normal. So it's the responsibility of all workers to follow all the client's plans in place, and clients might have one or might have multiple plans in place. So you've got support plans, you've got healthcare plans, positive behavior support plans, and these do need to be followed in a disciplined manner. That means you don't just pick and choose the parts that you like. You need to follow it step by step. You need to understand and demonstrate your understanding of the medication policy. You need to be able to follow organizational policies and procedures. and any willful deviation may constitute a breach of duty of care. What that means is you're doing something wrong and you know it, and you do it anyway. So driving the car with your client not having their seatbelt on, or driving the car and going over the speed limit, even if your client's seatbelt's on or not, okay? These are all breaches of duty of care. And everyone's responsible for their own actions. So if we draw our attention back to that really important point of not giving medication that you didn't prepare, if you gave something that you didn't prepare and something went wrong, you're still responsible because you chose to give that medication. So our responsibility from an organizational perspective is that we need to have all of our systems meet legislative responsibility. And we do. We meet all state and national based legislation in which we work under. So you do get orientation. Now, in order for you to have met this assist with medication, you need to have completed orientation. So that's good. You need to ensure that you understand your scope and role. So if you're employed as a support worker, you shouldn't be acting in duties that are expected of a CSC or an RM. Okay, so work within your scope and your role. We do offer continuous training. So if you need to work with a client with dysphagia, for example, a difficulty in swallowing, we'll give you that training as well. Okay, so we provide all of that training dependent on your needs. We support you in accessing information regarding to policy, procedure, and anything that is specific to the client. So if you're new and you don't exactly know all the things you need to know and where to go to find them, that's absolutely fine. We're not expecting you to remember everything today. So you're welcome to call your CSC, ask them, call admin, head office, asking, where do I find this? They will help you, they'll direct you, and if they can't, they'll direct you to someone that can direct you. Okay, so you're always supported, and I never want you to feel like you have to do this all on your own. Okay, so you should have your colleagues that you work with, and you've got your upline, so your CSC, RM, all the way up there. Okay, so you're well supported when you do give medication. So speaking of, let's get into it. So a medication is essentially a substance which is intended to affect the structural function of the body. Okay, so nearly anything can be a medication. So we talk about prescription medication. So medication that you go to your doctor, the doctor writes up a script, you take it to the pharmacist to get filled and they give you the medication. Then you've got non-prescription medication or all over-the-counter medication. You walk into Coles, Woolworths, the pharmacy, anything you can buy off the shelf, that's what they count as. So they can be vitamins, any pain relief, paracetamol is a good example, and any topical treatments, creams, lotions, and any complementary medicine. So homeopathic, naturopathic remedies, supplements are a good example of that. And non-Western medicine also fits into this category too. The clients that you may work with might have an array of various types of medication. It's important that if you're working with them, you understand and you know what they do. Okay, so some important notes to remember. To safely administer medication, you need to know the 8 rights, and we'll cover that briefly. We're going to check the medication 3 times, and I will go over when we do check how many times we check and at what points that we check in that medication process. And you need to be able to check between the medication chart, which has the doctor's orders on it, as well as the medication container. So a lot of the time you'll find the medicine is in Webster packs, but otherwise it could be in loose containers too. Okay, so you're checking the entire drawer where medication is kept for your client to ensure that you've got the right medication. And a really important thing that I want to reiterate, if you prepare it, you must give it. No one else is responsible other than you if you're giving it, so you need to check it first. So what you see there, the arrow pointing to it with a red label on it, that is your long-term medication chart. These are what we use. It's what the doctors write on to write up the medication orders. It has to be clear and legible. Okay, so you need to be able to easily read it. It can't be the scribble that you usually see in TV shows and movies that no one can read or understand. It needs to be really clear. Some GPs have gotten to the point where they're choosing to type out and stick on the medication, and that's absolutely fine too. On the right there, what you'll see is the medical appointment summary sheet, or MAS as it is otherwise known as. So the MAS is where you can find extra additional information that isn't normally found on the long-term medication chart. So things like side effects, intended effects, how long it's meant to be going for, other interactions with medication, can this be taken with some foods and other foods, really depends. Okay, so all of that extra information can be on the MAS, but be aware that it's not a legal order from the doctor, so that the doctors don't legally have to write on it. They can. It helps us greatly, and staff really do benefit from having it written out. So some GPs might spend a lot of time and really fill it out well. Others will kind of put a little bit of information there, and others will refuse to do it. Okay, that's actually fine. That is their right to do that. All that information, all of the important information should be on the long-term medication chart. Okay, so considerations all go on the front, and I'll show you all that in greater detail as well. Okay, so what you're looking at there on your left, the long-term medication chart, that's where you should find most of the information about the medication you're giving. So let's talk about the 8 rights. So in no particular order, we've got the right person, the right medication, the right dose, the right route, the right time, the right documentation, the right reason, as well as the right response. So all 8 of these rights at some point need to be considered, and some need to be considered multiple times. Again, I'll cover this in the practical demonstration. So what we like to think of the rights as is as a cyclical process. So you're constantly thinking about them, you're constantly going over them. So as you're checking the medication, you're making sure that you've got the right person and the right medication all the way around. And once that medication's been given, you are checking for the right response. So has it worked? Has it not worked? What does that look like? And I'll cover that in more detail right now. So the right person. You need to check the medication authorization, so that's the medication order, so the long-term medication chart, with the pharmacy labels on the Webster packs. Okay, it's really simple. The names must match, the date of births must match, and the photo ID also must match. Okay, if there's any discrepancy, if there's anything that's wrong or incorrect, that needs to be followed up, and it's not safe to give the medication. Okay, nicknames should never be used. So if our client, their full name is Gwen Walker, and Gwen prefers to be called Batman, and we refer to Batman every day in our common interactions with them, that's fine. But when we go to the medication chart, when we go to the Webster pack, what we're expecting to see really is their full name, their full legal name. Okay, so even if Gwen was the nickname, for example, and their full name was Gwyneth Walker, and we refer to Gwen all the time, we would still expect to see Gwyneth Walker. Okay, so it needs to match exactly. And we do use photo identification. This has to be updated at a minimum every 6 months. But if there are any major changes to your client's appearance, so they cut their hair significantly, they change their hair color, they lose weight, they gain weight, anything that is of noticeable difference, we're taking a new photo and adding it. Okay, what this does is it ensures quality. So if you're not working today, for example, but there is an external person, an agency person working, they need to really make sure that they know who they're working with and that they've got the right person. And do be careful. Some clients do live in houses where other people share similar names. So you might have a Jack and a Jake living together. So it's really important that we're extra careful when we're checking our medication charts and Webster packs. So the right medication. The medication name on the label must match the medication authorization exactly. So it needs to be word for word. It can't say one thing on the med chart and then on the Webster pack say something else. Otherwise, we can't give it. We can't confirm that they're exactly the same drug. Okay. All medications do have a generic and a brand name. So I'll cover that a little bit more in the next slide. But really importantly, we should only be accepting generic names. Okay, so in the example of paracetamol and Panadol, so paracetamol is the generic name, and a brand name is Panadol, or is Panamax, or is Hedanol, or and many of the other varieties, okay? So the generic is what we want to see on the medication chart and the Webster pack. And they do have similar names, and they can do different things. So it is so important that we're double checking everything. So Velpam, Velpro, they sound similar. If written poorly, can even look the same. So we've got to be extra careful. We check the right medication. We're making sure that the generic name is there, diazepam or sodium valproate. Okay, so we want the generic name. Paralgin or Paralise. Okay, again, they sound the same, but they do very different things. One is for pain relief, and the other one treats head lice. You don't want to make that mistake accidentally. If you can't read it easily, don't do it. Don't give the medication. It's not safe to. It's not worth risking your client. It's not worth risking your role or your job. Okay, so don't give it. If it is that unreadable, you can't read it at all, you and your client need to book a GP appointment and get it rewritten. Okay, it's not fair to you, and it's not fair to other people that they have to guess what medicine is there. It's not safe, and it's illegal to be giving medication that you cannot confirm. So here is a visual example of that generic versus trade brand name. Okay, so the generic name is really small there. You may or may not be able to read it, but it does say diphenylhydramine. Okay, that's the generic name. But what that does is it's an antihistamine. So for nasal congestion during spring or any exercise, essentially, depending on the individual. So your client might go, can I have some Benadryl? Or they might even go, hi, like, hey, I need my antihistamine today. My allergies are flaring up. You know what that means. So you go get diphenylhydramine. So that's what you're checking in the med chart and on the box, or you're checking it in the Webster pack, okay? It should say diphenylhydramine. It cannot say Benadryl. So that can be frustrating at times, especially if doctors feel the need for some reason to write the generic name, to write the trade name when they need to write the generic name. So if you're there as the GP is writing all of this up, you need to make sure that the GP is writing up the generic name. So once they're finished, before leaving, check the medication chart, make sure it's easy to be read, it's easy to understand, it's all very clear, and that they're using the generic names. All right. If they're not, then you can get them to quickly fix it in front of you. So that last point there, paracetamol over Panadol, what are other medications that you know the generic and trade name of? It's often, most people don't. We talk a lot about the trade names, and we might know Nurofen, for example, but the generic name is ibuprofen. So completely different, sounds nothing alike, ibuprofen and Nurofen, maybe the fin at the end, but beyond that, most people wouldn't even know that they're the same medication. All right, so it's really important that we're using the generic name. The right dose. So the third right here is ensuring that we don't give too much or too little, but we do give the right amount as per the GP's instructions. Okay, so we do use symbols on our med charts, and it's really important that we use the correct abbreviations, and we'll go over some of that too. And again, if it's not clear, don't do it, don't give it. Double check. If you look at the long-term medication chart, on the back of it, you will find that there is a cheat sheet of all the abbreviations that are allowed to be used. So if you see an abbreviation used on a medication chart, but you're like, oh, I don't know what that is, I've never seen that before, check the back of the medication chart. That's where your answers will be, okay? So we do use medication strengths in shorthand, but now we use longhand for others. So micrograms is no longer written as mcg. It must be written as micrograms. We can no longer accept mcg because mcg, when written even a little bit messily, can look like can look like milligrams, and micrograms and milligrams are completely and utterly different. We don't want to overdose or underdose our client because we made the mistake of reading it incorrectly. All right, so micrograms has to be written out in full, but still milligrams can be shortened to mg, grams to g, and milliliters to ml. And what you can't see due to my face being there is that liquid medications are prescribed in milligrams per milliliters, So what you're missing there is the 5 mil. So 200 milligrams in every 5 milliliters of the liquid. So if our client needed 400 milligrams, we would do that simple maths and we'd double that, and we would get 10 milliliters, so that our client would get the full 400 milligrams. Okay, if you do ever find yourself needing to do calculations or maths to get the right amount, feel free to use a calculator. No one's expecting you to guess. Okay, so always be careful, always double check. Number 4, the right route. So you need to confirm that the person can take or receive the medication by the ordered route. It's really that simple. Review the medication chart and make sure that it all matches against the Webster Pack too. It also has to make a lot of sense, right? We're not going to be administering eye drops in someone's mouth. Okay, you really don't have to think too hard about this, but use common sense. And we do have different routes, so I'll cover them now. So enteral, so these are things that, well, I like to think of it as entering the body. So oral, sublingual, so sublingual is under the tongue and it will just dissolve. Buccal is the same as sublingual, but it's in the cheek. Nasogastric tube is a tube from the nose all the way into the stomach. An orogastric tube is from the mouth all the way into the stomach. A gastrostomy tube is a tube from the outside directly into the stomach. And a jejunostomy tube is from the outside into the intestines. And then you've got rectal as well. And then you've got topical there. So any topical preparation, and it does include their mucous membranes, but each one of these will have a very specific route written down. So topical, think on top of the skin. So any skin preparations, creams, lotions, moisturizers, okay, anything like that needs to go there. Transdermal patches, so the most common one people will probably be familiar with are nicotine patches. And so a nicotine patch is something that we might apply to a client. Really important that with anything that we prepare outside of oral medication, gloves need to be worn. If you're touching a transdermal patch, a little bit of the medicine is going to go into your fingers and you're going to absorb some of that nicotine. Okay, so it's important that we're wearing gloves when handling these substances. And then you do have the other mucous membrane based ones. So eye drops, it doesn't say it there, but ear drops, rectal and vaginal creams and lotions, bladder irrigation, nasal and throat sprays. All of these have their own route and can be found in the abbreviations list on the back of the medication chart. Then you've got inhalations, so aerosol therapies, metered-dose inhalers, things that we're thinking asthma, right? So those puffers that people use. And then parenteral, so intravascular, so intravenous, intramuscular, and subcutaneous. So these are not things that you'll be giving unless you get specific training. Subcutaneous is the only semi one that you give, and you get training in this Assist with Meds training on using an EpiPen, and that does technically have a needle, but it's straightforward. So if you end up working with a client that does need subcutaneous injections for, say, diabetes, you would get specialized training for that. So don't worry, you're not going to be giving any needles unless you get specialized training. And there are some of those abbreviations. The biggest thing to kind of watch out for is if you see the letter P in front of them. So PO there, you've got PR, PV. The P just stands for per. So per oral, per vaginal, per rectal. The fifth right time. So medications are prescribed at particular times, and it's really important that they're given at the right time. So this is to prevent irritation to the stomach, to assist with absorption, and to maintain a constant level of that medication in the body. All right, so a good example is ibuprofen, if we refer back to that one. Ibuprofen taken on an empty stomach can cause ulcers in the stomach lining. Okay, so we need to make sure that ibuprofen is had with food or had after food, and that helps with absorption. Ibuprofen is best absorbed in the intestine, so that is the best way to do it. So with food, because the food helps it travel from the stomach into the intestine. And to maintain a constant level of medication in the body, that is really related to things that have to be specifically given on time. Antipsychotics, antidepressants, contraceptive pills. Okay, and if you give it at the wrong time, they can be proven to be ineffective. All right, so the contraceptive pill is a good example. Taking it too late or taking it a day after can really mess up a person's ability to prevent themselves from falling pregnant. Okay, so it needs to be given at the right time. And do always check when that last dose was given. Never assume that just because it's 12 o'clock and it's due for now, that it hasn't already been given by someone 5 minutes before you. Okay, so really always double check that. And above my head there, you've got the 24-hour clock. Okay, it's also known as military time. We use this, we don't write AM or PM. It needs to be in a 24-hour clock. So if we're talking about 10 o'clock at night, we're writing 2200 hours. Okay, really easy way to become familiar with this process is by on your phone, changing the lock screen time to reflect a 24-hour clock and not the 12-hour clock that you might be more familiar with. And it'll only take 2 to 3 days for you to really know what that 24-hour clock is saying, especially if you're unfamiliar with it. So there are some abbreviations there. A lot of these abbreviations are based in Latin. We haven't moved past a lot of them. I wouldn't worry too much about it because you've got the abbreviations cheat sheet on the back of your medication chart. So don't worry too hard about that one. But it's really important that PRN probably is the one that is most confusing to people. It means pro rata. You don't have to worry about that. But what you'll see it on as the medication chart is when it's required or as required or when it's needed. Okay, and that's medication that's not a regular medication. It's a medication that might be requested or it's an every now and again thing. Paracetamol is a good example. People often don't need paracetamol 4 hours a day. It's, I've got a headache today, so I'm going to have some Panadol or paracetamol. Your client will come up to you, they might request it, or at times you might realize that they need it before they do. Okay, so it's a when they're needed, and these medications can be found at the back of the medication chart. So let's say you miss a medication, you got to review their management plan. You're checking for adverse events and effects. Often the best thing to do is to call a pharmacist and go, hey, look, my client's missed this medication. Is that something that I need to be concerned about? What advice do you have? And they might be able to tell you, okay, look, I know it's 2 hours late, but it's fine to give it. Okay, you're safe to give it. Don't worry about it. Just document that you've done that. Or they might go, nah, you know what, don't worry. Just wait until the next dose. If it's outside of the time that the pharmacist is open, you can call Poisons Line. Sorry. So you can call the Poisons Line. They're 24/7 and they'll be able to assist you a whole lot better during that period where the pharmacist isn't open. So again, if you miss it, you go to the CMS and you fill out a MIR, so a medication emergency and incident report form, and you just note it on the medication chart too. You only ever need to contact your coordinator if it's requested in the client's management plan, but otherwise you're in control here. Just document it. The MIR goes to your coordinator or your CSC, so it goes to them and they'll review it and they'll action it if it's needed. And if a client does vomit or spit up medication, be sure to call the pharmacist to see what is safe to do. Okay, it's no good you guessing that it hasn't been absorbed or it has been absorbed. Call them, tell them what the time was that you gave the medication, when they've vomited it up, and they should be able to provide advice to you. Based on that advice, what you'll end up doing then in the MIR is you'll go, spoke to Adam the pharmacist from Terry White Chemist. Adam suggests that the client shouldn't take the medication again and they should just have the next dose at the right time. And then that's what you do. So you need to document that as well. So you can document that in the MIR or you can document that in the communication book. Yeah, so this is probably the greatest part of the medication dosing is that leeway of the 2 hour window. So the 2 hour window refers to 1 hour either side of the due time. So in that big red box there, if a medication is due at 8 o'clock in the morning, it can safely be administered between the hours of 7 and 9. Okay, so if the medication is due at 1 each day and you notice at 1:30 that you've forgotten to give it, don't stress. You can give it at 1:30. You just sign it just like normal, and that's it. You don't have to fill out a MIR. You don't have to tell anyone. It's all good. Okay, so you just document that you gave it and that's fine. It's also really helpful if your client needs to be out of the house at, say, 9 o'clock because they're going to the city that day, and you're leaving the house at 8:30, but their medication's due at 9. Give the medication between 8 and 8:30 before you leave. It saves you packing. It saves your client any potential embarrassment or shame in having to take medication outside of the home. A lot of people aren't really that comfortable taking medication outside of your home, and clients are no different. Okay, so it means the day goes so much easier. It's so much nicer. So do check, and if it is outside of that period, call the pharmacy. They'll be able to provide advice, or again, poisons if they're not available. So the medication falls on the floor, your client drops the medication, could be anything. Pick it up with a tissue or use gloves to pick it up. Never pick it up with your bare hands because you can still absorb it. You want to take it to the pharmacy to dispose of, okay? So however you do that is up to you. You know, tape it to a piece of paper, put it in a little container, but it has to be taken to the pharmacy. It doesn't get thrown in the bin, doesn't get thrown in the sink or the toilet, okay? What you do in your personal life is completely up to you, but when it comes to clients and their medication, we do not throw it in the bin or down the sink. I suggest never throwing anything down the sink, especially things like antibiotics, because the bacteria in the piping and the tubes can become resistant to that bacteria, and obviously that bacteria grows and flourishes and spreads and naturally re-enters the population. And if you ever got sick from that, it might mean that you'd be unable to take the antibiotic because the bacteria is resistant to it. So just be super careful. The sixth right, so the right documentation. It's your legal obligation to recall all medication administration. That's as clear as I need to be for that one. You document it immediately after it's given. Don't document before, because if your client refuses and you've already signed for it, you're in a bit of a hard spot there. Okay, so don't sign it until you've seen your client swallow it. You give your initials in the little box on the med chart, and you make sure that the time and date are really matched. Okay, you don't want to sign into the wrong box. Don't record the medication until it's been swallowed. Fill out a MIA if any incidents do occur, like they've refused, they've thrown it away, they've spat it out. Lots of things could happen. And number 7, the right reason. So this is probably the thing you want to think of first before you give any medication. What's the reason you're giving it? What does this medication do? If your client came up to you and was like, oh, what medication are you giving me? What does that do to me? You need to know. You need to have a really simple and easily understood explanation for what that is, okay? So you need to make sure that it matches the history. So is our client on anti-epileptic medication because they've got epilepsy? I mean, that makes a lot of sense, doesn't it? But you got to check, otherwise you don't know. You need to revisit the reasons for long-term medication use with a GP every time. So every time you have a GP or a specialist appointment, you're just taking the med chart, double checking all the meds are still relevant, they're all still a good dose, and that the client needs to be on them. Now, you need to refer to the MAS if you want any of that additional information. But again, like I said at the start, it may not have it. Okay, and that's really, really important for us to remember. The other place that you can go to get information on medication that is easily understood is the Consumer Medicine Information. Okay, Consumer Medicine Information, or the CMI, is online. It's from the Australian government, and it covers every medication that is prescribed in Australia. Okay, every single one of them. So if you come across a medication you've never seen before, check the CMI. Now, each medication of the CMI should be printed out in a blue folder on site regardless. But if you're coming to a brand new site and that hasn't been done, you might be the first one to do it, okay? So you check the CMI, you print them out, and you take them and keep them on site for other staff members. And finally, the right response. So after we've given medication, after we've signed for it, we want to make sure it's led to the desired effect. So if our client had headache and we gave them paracetamol for that, we're checking in an hour later. Hey, how's that headache of yours going? Yeah, it's good. great, that means it's worked. Or they go, nah, it's still there, it's terrible, it hurts more. You go, okay, it means we have to do something else. We document that, obviously. We talk about side effects. Were there any other reactions? We're always observing our client. So we're watching them, we're talking to them. They'll tell us if things go wrong. Perhaps they won't, perhaps they can't. We have to watch out for other tells and other signs to know that things are not quite right. Okay. Now, if any monitoring does need to occur, so you might be checking someone's heart rate before and after medication. Blood pressure is another good example. You've got a special sheet that you're going to fill out every single time you do that. And unexpected reactions can occur even after a client's been on medication for 20 years. So even if you feel confident and your client feels confident that the medicine is going to work, you're still observing, kind of in the background there, always just thinking something could potentially happen. Okay.